Hello doctors, today we briefly learn about Meconium Aspiration syndrome. It's a small topic but kinda important for neonatal care. Some key points: meconium stain amniotic fluid occurs in 10 to 15% of pregnancy, of which 11 to 28 develop meconium aspiration syndrome in developing countries. PPHN is a major determinant of the need for intensive care and mortality. High frequency ventilation, inhaled nitric oxide, and ECMO can decrease mortality. Meconium aspiration syndrome is a respiratory distress syndrome in neonate resulting from inhalation of meconium stained amniotic fluid into the lungs before or during birth. It is more common in term and post term pregnancy and rarely before 34 weeks. So, what is meconium composed of? It includes desquamated cells from intestine and skin, gastrointestinal mucin, lanugo hair, fatty material from vernix caseosa, amniotic fluid, intestinal secretions, glycoprotein, and phospholipids. Pathophysiology. The passage of meconium in utero is often associated with fetal distress resulting from conditions such as hypoxia, cord compression, or placental insufficiency. When the fetus experiences distress, it may initiate gasping movement, leading to aspiration of meconium into the lungs. Once there is meconium into the lungs, can cause multitude of problems like airway obstruction. Meconium can physically block the airway. When complete blockade result in atelectasis, ventilation perfusion mismatch, and partial blockade produce a valve-wall effect. Air leak can occur and cause pneumothorax and pneumomediastinum. Surfactant inactivation. The component of meconium can interfere with the function of surfactant. Inflammation. The inhalation of meconium trigger an inflammatory response in the lungs, leading to damage and further respiratory distress and can cause chemical pneumonitis. Persistent pulmonary hypertension of the newborn (PPHN) in severe cases. MAS can contribute to development of PPHN. Neonate with MAS typically present with respiratory distress shortly after birth or within the first few hours of life. Common signs are same as respiratory distress syndrome: tachypnea, hyperoxia, grunting, retraction, nasal flaring, cyanosis. Chest X-ray finding in MAS can variable but often demonstrate patchy infiltrate, hyperinflammation, air trapping, atelectasis, pneumomediastinum, pneumothorax. Diagnosis of MAS is primarily based on clinical suspicion in a neonate born through meconium stained amniotic fluid. X-ray chest to evaluate lung involvement, VBG, ABG to assess oxygenation and acid-base balance, echocardiogram to assess for PPHN. Severity. The severity of illness is divided in mild, moderate, and severe. Mild disease requiring less than 40% oxygen for less than 48 hours. Moderate is more than 40% oxygen for more than 48 hours without air leaks. Severe disease requiring assisted ventilation for more than 48 hours, and it is associated with PPHN. Management of MAS depend on the severity of the condition. Supportive care can be given: IV fluids, preventing hypothermia, maintaining adequate oxygenation, O2 by hood, non-invasive ventilation. CPAP may be used for milder cases, invasive ventilation for severe cases. Surfactant therapy can be helpful, improve lung function. Inhaled nitric oxide in case of PPHN. ECMO can be given for PPHN, which is extracorporeal membrane oxygenation. Antibiotic have no role, but it can be used in case of sepsis, and steroid have no role. Complication: persistent pulmonary hypertension, myocardial dysfunction, air leak, bronchopulmonary dysplasia, shock, HIE. So how do you prevent MAS? Careful monitoring during labor, prompt recognition and management of fetal distress, avoiding post-term deliveries beyond 41 to 42 weeks, amnio infusion. Mode of delivery have no impact on the outcome. Thank you.